Thank you very much, Michael. As you said, I'm going to be speaking about a very specific topic, anterior cruciate ligament injuries, and not so much about what we do after they happen, but more about what causes these injuries and how can we prevent them if that would be possible. So as, just a quick background, and you mentioned this, Michael, I am from a little city up in northwestern part of Greece called Ioannina, and many of you probably have been to Greece, considering that we're in Europe, and you have probably been to this part down here, the Aegean Sea, Athens, Santorini, what I call as the nice part, okay? I'm not from this part, I'm from the northwestern part. As you can see, snow-capped mountains, it rains a lot, it rains all the time, and it's really pretty to look at it for a couple of days and then move to the islands, which is what a lot of tourists do. On Friday, Michael was talking about Denmark and how happy people are there, and he said that Aalborg is probably the happiest city. I have some evidence to say that Aalborg, where he's from, is the happiest city in Denmark. My anecdotal evidence is that Ioannina is probably one of the unhappiest cities in Greece. So after finishing high school there, I went to Thessaloniki, the second largest city in Greece, and I did my undergraduate in physiotherapy. Just like most Greek students, the first year I immersed myself into the student life, which is a euphemism for not going to school very much and prioritizing other things. I did graduate. And I was offered a job at the private clinic from somebody who was a role model for me, from the professor of musculoskeletal physiotherapy, who seemed to have forgotten that he failed me twice during my undergraduate years, and he offered me a job at his clinic. So there I was immediately right out of physiotherapy school at a very young age, working with professional soccer players because he was taking care of the team, the name of the local soccer team. The name of this team is PAOK Thessaloniki. Some of you may have favorite teams that played against PAOK, and obviously it was an excellent experience for me. It was very obvious, though, that I needed to learn more, and there were not many opportunities in Greece at that time. So I made a much longer trip over the Atlantic and into New York City, and I found a job, a position at a Master of Physiotherapy program at Quinnipiac University, which is 2.5 hours north of New York City, where I took the typical Master of Physiotherapy courses that you would expect, a lot of the serious basic examination, the more advanced manual therapy techniques, Maitland, Mulligan's, manipulations, and so on and so forth. It was a quite unique situation because back then, and that was 20 years ago, they offered a course in the psychophysiology of pain. So that was way before David Butler's work and all these other pioneers in this area. Where I was introducing the concept that pain is not only the symptom of injury and disease, but it can be its own entity, and that has influenced my practice a lot. I also took a lot of courses that were very popular back then, and I'm glad to report I haven't used in decades, such as craniosacral therapy and myofascial release. Long weekends over the summer learning about these courses, which now we know these techniques don't do much. However, a pivotal moment for me was when I took a physical biomechanics class, because as a high school student, I really liked solving mechanics problems. So I really liked math, and I found a lot of comfort in solving a problem and then looking back to the solutions at the end and then coming up with the correct answer, 175 Newton, or the wrong answer, and then going back and trying to find where the mistake was until you come up with the correct solution. So that's, unfortunately, that's how my brain worked. I liked this one answer, and it was, a bit disappointing that in medicine and in physiotherapy, you can read as much as you want. You can be the best in terms of knowledge, and you will still not be able to treat all your patients quite effectively because there is a lot of variations of gray in clinical practice. However, biomechanics allowed me to combine my desire and that part of my brain that liked a concrete answer with my love for treating patients and for physiotherapy. So biomechanics integrates physics, engineering, and human motion, and it's a bit more concrete science than some of the clinical part of physiotherapy. My clinical approach has also evolved over the years. I do strongly believe that the more successful physiotherapists are those who practice with empathy. And we have some data to demonstrate that physiotherapists actually are very good at abusing their body and their soul. There is a high burnout rate. We have a group in Sydney with some other researchers where we do research in this area. This is a secondary area of research for me. And that has to do with how do we protect the clinicians from burnout and from other bad things. Okay, so I'm going to play you this quick video that talks about blind spots. If you've seen it, don't yell out the answer. For the rest of you, try to count how many passes the team the basketball team in white makes. Okay, they're going to start. So count how many passes does the team in white make. And stop. How many? Yell it out. How many passes did you count?
13.
13. Okay, and this is the correct answer. Some people may have said 12. The correct answer is 13. But did you see the moonwalking bear? So let's reverse the video and take a look. And now if you look towards the center of the video, here's the moonwalking bear. It was there before, waving at us, and we missed it. So this, to me, summarizes visually what commonly happens in clinical practice, where we are looking for a specific thing, whether that is the sacroiliac joint or something else, just because we took a continuing education course, and we find it. Okay? However, we are commonly missing something that is much more obvious and frequently much more important. So as clinicians, I do believe that one of the more difficult aspects of our jobs is to demonstrate the empathy and the soft skills that we have to demonstrate towards our patients, because they are disabled and they are vulnerable at that time, and that is an essential component of a successful clinician, and at the same time become a fly on the wall, a very smart fly on the wall, where we look at the data as objectively as we can and we analyze it. And switching between these two roles is probably one of the more difficult things that for clinicians. Also, natural history in musculoskeletal diseases plays a major role, and we need to keep this in mind as our patient makes progress or not. And as I said, accept the reality that we cannot help all our patients. That was just some general comments about my clinical approach, and don't see patients. Actually in Sydney, I don't see patients at all. And before, when I was in New York, I would just see patients on a part-time basis. But you know, obviously, it's a very my clinical practice. It has a very evolving nature. So over the course of these 3 days, we spoke a lot about injuries, because they are an essential part of sports and fitness. You cannot have one without the other. And we spoke about injury in generic terms. We had Eric talk about injury overall and then categorize it in acute and non-acute. We had Tim Gabbett on the first day talk about total injuries. And we had an orthopedic surgeon yesterday morning speak specifically about meniscal injuries. So my topic is much more specific. So I'm going to talk to you about anterior cruciate ligament, which is a ligament in the center of the knee, the most important tissue in the human body, and how can we prevent it, and what happens when this ligament breaks. Actually, I'm not going to talk to you even about all ACL injuries. I'm only going to talk to you about the non-contact ACL injuries, which are the majority of these type of injuries. Now, you would think that we would have very good data at how many ACL injuries happen because it is a rather devastating injury. When it happens, almost always, the patient seeks some medical care. So you would think that we have some way to document how many injuries happen. And the sad reality is that we don't. Our friends from Scandinavia have developed some registries, but these are exclusive to the reconstructions. Okay? So an ACL injury can be treated conservatively or can be treated surgically. And there are a few countries around the world that have developed registries. We have one that is developing in Australia as we speak, with mixed success at this point. And these registries provide us some information about how many reconstructions happen. How many injuries we don't know. We assume, and that is, somewhat of a guesstimate, that for every reconstruction there is one ACL patient who chooses to be treated conservatively. In Australia, we have about 10,000 ACL reconstructions a year at a staggering cost just for the reconstruction of 75 million Australian dollars per year. In France, they have an ACL database. Again, there's no information there about cost. And there is a very wide variation of how many reconstructions per 100,000 people in the general population happen across the different countries. So, for example, we had a PhD student, Thiago Lopez, who did research comparing the ACL reconstruction rate in Brazil, where it is only 3.5 people per year per 100,000 people, while on the other end of the spectrum, Australia is an outlier with the highest number of 52. Scandinavian countries and the US is between 30 to 45. So there is this wide variation, to a large extent socioeconomic factors, probably to a very large extent due to the availability of surgeons who know this technique and feel comfortable performing it. We also know that there are a few groups that are at higher risk for suffering an ACL tear. For example, when we compare apples to apples, so women who play basketball at a semi-professional level to men playing basketball at a semi-professional level, women are at a much higher risk of suffering an ACL injury. Again, there is more males having an ACL reconstruction than women, but this is because they play sports that are more dangerous and they play those more frequently. But when you compare exactly the same groups between males and females, and we've known this for 20 years now, are at a higher risk. This is really bad for women. From a research point of view, it's good to have a group that demonstrates higher prevalence, because then if you study them, then you hope that actually you can figure out why these injuries happen. We also know that for those athletes who tear their ACL and they have an ACL reconstruction, if you follow them for a few years, they are at a staggering 15 times greater risk for tearing either the reconstructed or the intact ACL than the group that never had an injury. So again, really bad news for them. If you suffer one ACL tear, then the risk of suffering another ACL tear, either of the intact ACL or the graft, are much higher. From a research point of view, again, if we study them, maybe we can gather some information about why these ACL injuries occur. So when we started realizing the extent of the problem with ACL injuries, the government started saying, well, let's bring the experts in the hotel room and make this consensus conference, which is a very unique type of meeting, because they bring people from all over the world. They don't always necessarily get along. They lock them into the room and they say, well, here's all the literature. Assess the literature. We're not going to unlock the door until you actually reach a consensus. And that's a good incentive. The first one in 1999 in Georgia in the United States listed the potential risk factors for ACL injuries, and some of them could be environmental, and you can see here, weather, playing conditions. There is a little bit of evidence to suggest that if the weather is a bit wet and the surface more slippery, that ACL injuries are maybe a bit less likely to occur, as opposed to completely dry surface that increases friction between the shoe and the surface. They looked at footwear, bracing, and a lot of other environmental factors. I also discussed some of the anatomical factors, such as the Q angle. There is a little bit of evidence that some of the morphology of the knee may predispose some athletes to a higher risk of ACL injury, such as the width of the notch, which is, the area between the lateral femoral condyles anteriorly in the knee, and also the slope of the tibial slope when you're looking from the side. Again, not strong evidence, and there's not much you can do. Or you can only change this factor surgically, and that would be unwise in terms of, you wouldn't do that for preventing an ACL injury. Body mass index, a bit of conflicting results there, probably more of a major role in military training than in the general athletic population. The ACL also has hormonal receptors, and people have thought that hormones play a role in the risk for ACL injury. Again, the literature is very inconclusive. There is a lot of technical issues with assessing the exact part of the menstrual cycle that the female athlete is in. Genetics, and we are currently doing some work in this area. There are a few laboratories that have identified specific genes that are related to collagen that may be associated with an increased risk of ACL injury. But the rest of my talk is going to talk about neuromuscular and biomechanical risk factors. Consensus Conference in 1999 identified those as the most promising, not only because they have the most evidence in terms of being associated to risk for ACL injury, but more importantly because they are potentially modifiable. Okay? Let's take a look at an ACL injury, and let's see how that would happen before we move on. I'm going to take a short pause here before I play this video to allow you to create your own stereotypes. So stare into this guy's eyes and try to find out who he is, where is he, what he's going to do. I can tell you that he's going to show us some soccer tricks that he just learned. And he's going to demonstrate that on the camera. When I first saw this video, which has been, quite some time ago, my stereotype was that this guy is from Ireland. Now, I don't pretend to know too much about Sean, but here he's with his new leather jacket. He seems like a really nice guy. He likes to play soccer, obviously, so he meets with his friends. He goes out regularly to do sports. He's a good student, he wants to do well in life, and he wants to go to the university. He goes to the university to study computers. He meets his love of his life there, Sinead, another typical Irish girl. They fall in love. He finds a job in IT, in information technology, at a bank. They have 2 children and a dog. A couple of times a day, a couple of days per year, when it's sunny in Ireland, they go to the park. And when Sinead allows him, he goes out and he does sports with his friends. So now, obviously I don't know much about Sean, but I think that's a good guess about how his life was expected to go. What I will present to you is that what we just witnessed was a pivotal moment in Sean's life. This exact moment when he tore his ACL. So he'll have to go to the doctor, or maybe have surgery possibly. He's a young athletic guy. He'll be on crutches. That's expensive, anywhere in the world. Physiotherapy, surgery can be quite expensive. His marks will suffer. So maybe he's not going to get into the university or the major that he would like. He cannot keep up with his friends anymore. He's feeling a bit blue. He stays home a lot. When he goes out, he drives because of his knee pain and the disability related to his knee. In a few years later, he's going to develop knee osteoarthritis, and that's going to slow him down even more and create this vicious cycle of less activity, more knee pain, and so on and so forth. And then a couple of decades later, he's going to find himself in Dublin feeding the pigeons in the park. All that sounds like an extreme exaggeration, especially since probably Sean is not even his real name, right? So how would I possibly know those things? However, there is levels of evidence to support each one of those statements. Well, maybe not the last one about the pigeons, but certainly the rest. So rehabilitation alone, the cost of that in the United States after an ACL reconstruction can be up to $17,000. Okay? So it is an expensive procedure to have. There is evidence to show that for university students who tear their ACL, the following 2 semesters, their marks suffer. Okay? So there it goes about academic performance. There is a high level of depression symptomatology associated with patients who show up to the doctor with an ACL injury. More importantly, and maybe that's one of the key messages that we can take from this presentation, is that ACL injury is highly associated with the development of premature knee osteoarthritis. And here we have, and like sometimes we read the studies and they go on for like 10, 15, sometimes 20 years. And we're thinking 20 years is a really long time. So who cares basically, if 20 years later you develop knee osteoarthritis. Keep in mind ACL injuries peak at age 16 for women, age 18 for men. So we have these large numbers of young people in the late 20s, in their 30s, at the most productive parts of their life, who have disability and symptomatic knee osteoarthritis because of an ACL injury that they have during the teens. And this is a devastating clinical problem because we have no good solutions. This is the young athlete who wants to be active with the 80-year-old knee. And what do you do with them? Knee replacement is probably not a good choice for them. Physiotherapy can only provide a little bit of a help, but not much in terms of helping with the disability. So I hope I convinced you, based on all this, that what we really need to do is concentrate on prevention. Occasionally I'll get a question that says, well, what's the big deal with ACL injuries? If a cousin of mine had it and now he's playing soccer again. I've heard of this athlete who's came back stronger, and Zlatan Ibrahimovic, for example, and he plays really well. So if I tear my ACL, I'll go to the surgeon, have it fixed, I'll be as good as new. Not nearly. We have published a few different studies with a group in Greece, but also this is consistent across the literature, that even after an extensive rehabilitation program, even after ACL reconstruction in the hands of some of the best surgeons, there are still remaining deficits in kinetics, kinematics, in performance, in strength for years, if not decades, after an ACL injury. To give you an example, we did a study where we looked at knee flexion strength after a hamstring graft ACL reconstruction. Typically, this is measured with the athlete in this isokinetic dynamometer, with the athlete having the hip at 90 degrees and pulling back. How functional is this position? Unless you work, in Japan with sumo wrestlers, this is their functional position, right? For the rest of us who work with volleyball, basketball, handball, soccer, this is not a functional position. So we wanted to see if these strength deficits were different when you have the patient prone, the athlete prone, and the hip in neutral, and they're pulling, you're measuring the strength from that position. And we did find that the strength deficit is higher, not by much, 5 to 7% usually, but enough to move them from the ready to return to sports category to the not meeting the criteria to return to sports category. So the take-home message for clinicians here is that choose a functional position for your athlete in terms of the sports that they do and measure strength in this position. We are in Germany, and of course we have to speak about Bundesliga, the local soccer team. I don't know if you have any Bayern Munich fans here. You may recognize if we have anybody a bit older, you may recognize this guy, Sebastian Deisler. Hope I'm pronouncing his name correctly. He was a big hope, a big talent in Germany. You see him playing and it's like magic, and he suffered multiple ACL injuries. I think he retired in his late 20s, never lived up to the potential and the hopes of the German people. But this is just an example, a local example, relatively local example of an athlete whose career had to be cut short. He was very public about some of the psychological issues that happened after this ACL injury. Again, just one example of how devastating these injuries can be. So if you look at what happens after ACL reconstruction and the deficits that we have, and we look only at some of the higher level evidence in terms of systematic reviews and meta-analysis, consistently there is lower knee flexion, range of motion after ACL reconstruction. So even with gait, our those who had an ACL reconstruction don't fully extend and don't fully flex the knee, not by a lot, but consistent finding. There is a rather consistent body of literature demonstrating that the tibia rotates internally more than the other knee. Okay? So the ACL reconstruction can prevent, to a large extent, the excessive anterior translation of the tibia, but it's less effective in preventing the internal rotation. Again, the same pattern where they don't propel. When they propel during a hop test, they don't fully extend. When they land from a hop, they don't fully flex. Kinematic deficits have been quite consistent. Strength deficits that are specific to the ACL graft. So when you see patients with a bone patella tendon bone graft, greater deficits with knee extension. When you see those with your hamstring grafts, greater deficits in knee flexion. And it is possible, again, it's a theory at this point, about why exactly do patients with after an ACL injury develop knee osteoarthritis. Is it these deficits that surgery does not fully restore? Is it the trauma from the injury? We cannot really say with any level of certainty at this point. And plenty of evidence to demonstrate that there is an increased risk of knee osteoarthritis after an ACL injury. As we said, it's a devastating clinical situation. The young person with the old knee, 10 to 20 years after an ACL tear, about half of them have osteoarthritis with associated pain and functional impairment. Now, you would think that ACL reconstruction decreases this risk. Again, the literature is quite consistent that it does not. Even though those who have an ACL reconstruction may be at a better position to return to sports, have a long-term, when we look at knee osteoarthritis, and ACL reconstruction does not prevent it. Also, when we look at the risk of having a total knee replacement after an ACL reconstruction for the next 15 years, again, it's quite high, 7 times higher than the rest of the population. Of course, having suffered a meniscal tear or a contra lesion, or if the surgery made the joint either too stiff or too loose, actually even worse if it is too stiff rather than too loose, then these patients are more likely to develop knee osteoarthritis earlier. So, how does this relate to biomechanics? There's a lot of studies that have proposed different motion patterns that may be associated with a higher risk of an ACL tear. The first one is referred to as the ligament dominance theory, and Eric, in some of his videos, he demonstrated some athletes who have this. It suggests that the athlete who lands from a jump or performs other athletic tasks with excessive knee valgus, hip adduction, and internal rotation, they're at a higher risk of ACL injury. Those who utilize the quadriceps more than the hamstrings, this makes biomechanical sense. Quadriceps on the front of the tibia, when they contract really strong, pull the tibia anteriorly, which stresses the ACL. Hamstrings on the back of the tibia, when they contract strong, they prevent the tibia from translating too much forward. Trunk, the human body is designed in a way where the majority of the mass is above the waist. So even small deviations in alignment in the trunk may predispose an athlete to ACL injury. And then finally, some of the work we've done and others around the world demonstrates that those who have some asymmetries in strength, in flexibility, more importantly, biomechanically. So this is your typical athlete that you tell them to do a bilateral task, and there's always one foot touching down first. Okay? No matter what you do, it's not as simple as saying, well, fix this. It will take much more effort. So these athletes, they're referred to as having a leg dominance deficit, and there is some evidence that this may be associated with a higher risk for ACL injury. In terms of ligament dominance, a few different study designs have supported this theory. We've done some work where we looked at female dancers and female athletes. Female dancers, even though they perform almost the same number of landings as some of the athletes, they demonstrate a much better alignment. In terms of knee valgus, they don't allow their knee to go in as far. Tim Hewitt did a very nice study back in 2005. He demonstrated that high knee valgus moment and angle are associated with ACL injury. And we also look, and that's one of the beauties of having a smartphone everywhere with a good camera. We capture a lot of these injuries on videos now, a lot. Sometimes, a teenager goes to play a game and there is the aunt in one angle with her camera and the uncle on the other end and then the parents. Then you capture the same injury from 3 different angles. And quite consistently, we see this same mechanism of injury that we saw with Sean earlier, where the knee collapses into excessive knee valgus. Some evidence to demonstrate that those who have this difference from side to side may be at a higher risk of injury. Again, when we compare the high-risk group, female athletes with a lower risk group, male athletes, we see higher asymmetries in females. Probably more convincingly, Tim's study, where he showed that difference, not only the magnitude of knee valgus moment angle, but also this high side-to-side different asymmetries are predictive of ACL injuries. Trunk dominance here, one of the coolest studies that I've seen from Billy Zazulak at Yale. She took her athletes at the beginning of the season at Yale University. She put a vest around them, and that was attached to a cable. She asked them to push away from the cable, okay? And then at random times, she released the resistance from the magnet. So what happened to the athletes? They swayed to the side. She had the marker on the chest, and she measured how far they deviated from the midline. Again, the athletes who demonstrated greater deviations, they were more likely to have a knee injury. And in the same population, she did another study where she used a device to passively rotate their trunk to, I think it was something like 30 degrees of rotation, passively move them back to neutral, and ask them to replicate that position. Those who were more accurate in replicating that position, they were less likely to suffer a knee injury. Some evidence in respect to the quadriceps dominance theory. 2 prospective studies that looked at athletes without an injury at baseline and then followed them to see who tears their ACL, one by Meyer, published in 2009. He isokinetically evaluated female athletes and then followed them on to see who tore their ACL. And he demonstrated that having lower knee flexion strength and higher knee extension, so consistent with the quadriceps dominance theory, is a predisposing, these athletes are at a higher risk of suffering an ACL injury. Zibis from Denmark, he did a relatively small study with 55 team handball players, and he did a cutting task where he measured EMG of the hamstrings and the quadriceps, and he demonstrated that there were associations between a lower hamstring to quads pre-landing activity with the risk of ACL injury. Again, in this study, maybe the researchers were a bit lucky to get enough power with only 55 athletes for a couple of seasons. Of course, the athletes were very unlucky to have a high number of ACL injuries here. So if we go back to Sean and we look at his successful landing, which is on your left, and the unsuccessful landing on your right, again, we can see some quite clear differences. So ligament dominance, so you see how the landing where he tore his ACL, he collapses into valgus, and also some track dominance. You see some really good alignment on the right, on the left, quite poor alignment deviating over the landing leg on the right. And a lot of these studies are, small laboratory studies, as we discussed. There were some prospective studies well designed. A better, from a research point of view, a better design would be where you capture the athletes before they get the injury. You take them to the biomechanics laboratory. You do lots of tests on them. Blinded, with multiple people, very consistent methodology, and then you follow them for a season or two. You don't want to wait too long because there's many other variables, especially in adolescents who grow quite fast. Then you follow them for a little bit, and then you find out who tore their ACL and who didn't. You identify the differences, then you go back and you are looking into whether can this study be replicated, and then eventually use this information to inform injury prevention programs. 4 years ago, we were lucky to get funding from the NIH to do a study that had a few advantages. First of all, it didn't suffer from selection bias. Okay? Frequently, we put a poster on campus and we say, are you 18 to 22, come into our laboratory. So who do you think is going to show up? Those who are more informed or our friends. So there is a bit of selection bias there. In this study, we went into, we worked with a school district in an entire county in northern Kentucky. And we captured 98% of the females who played basketball or soccer in this region, at the high school level, with buses that were brought into the laboratory in Cincinnati, and they were measured. And the task that we analyzed for this specific project is an unanticipating cutting task. So the athlete was, a bit behind the force plate, had two force plates. There was a traffic light against the wall. The traffic light was red. Then the traffic light turned yellow. That was their cue to get into the sports position. Then the traffic light turned green. That was their cue to jump. So they jumped forward towards the force plate. And then while they were in the air, an arrow pointed to the right or to the left, demonstrating the direction where they had to cut. Okay? So that was the unanticipated element that we're hoping that is going to make the task a bit more realistic in terms of translating into what happens in the sports environment. Because, again, usually our biomechanical studies are a few people, 20, 30, 40 people, if you're lucky. Here we had the opportunity with 721 athletes having high-quality biomechanical data to run some more unique statistics. So we worked with a statistician and we utilized this technique called latent profile analysis, which is a technique that is searching, a bit like data mining, is searching for common motion patterns among the different, among the population, and creates subgroups based on the similarities of the way they move. So we put into the model our ligament dominance variables, our knee valgus and hip adduction and rotation, our trunk dominance variables in terms of lateral deviation and rotation, our quadriceps dominance variables. We didn't have EMG or strength, so we used hip and knee flexion, which again is part of that theory there, meaning that those who land in a straighter position are supposed to suffer from quadriceps dominance deficits, and then our side-to-side differences for the leg dominance deficits. And after a few years of data crunching and a lot of work, you come up with this graph. Okay? So this graph here tells us the prevalence of the deficits in this entire population of 729 people. Now, stick with me because that is, seemingly a bit, in the first glance, a bit complex. But if you look right here, this is the mean. Okay? So when you see a group being at the mean, that means that this group is exactly in the middle. The demonstrate value is consistent with the average for the entire group of the 729 athletes. On the y-axis, we have standard deviations. So the further higher you are, that means that you're away from the mean. And if you look at this purple group, we name this the ligament dominance group, and they have really obvious ligament dominance deficits, 1.5 standard deviations above the mean. So 14% of the athletes, so a relatively small percentage, demonstrate quite clearly some ligament dominance deficits. 40% have no deficits. So if you follow the 40% group, the blue group, it's right in the middle, except towards the end where they have less asymmetries. And then we have the other two groups. And these two groups have a combination of deficits. And you can see here that one of them has a combination of quadriceps and leg dominance, and it's about a quarter of the total population, while the other one has trunk and leg dominance deficits, and maybe to a lesser extent a bit of ligament dominance deficits, and it's 22% of the population. So take-home message, 40% of your athletes probably don't need much training, much injury prevention training, because they, at least from a biomechanical point of view, of course there are many other factors that can lead to somebody tearing his or her ACL, but from a biomechanical point of view, they don't need much training and probably don't worry too much about them in terms of the risk for ACL injury. Your 14%, very, very high ligament dominance deficits, this may be the easiest group to pick up even with the naked eye or with a simple camera. The other two groups are a bit more complex. Okay, so this is nice and peachy. Prevalence of deficits. Let's say we identify those athletes who have the specific deficits. Can we prevent injuries? Well, the short answer is yes. Okay, so there are quite a few injury prevention programs that have been tested in the field. We had a student in our laboratory, and he did a study and systematic review. He found, looking at the FIFA 11 Plus, just one aspect of a program, and he found that the risk goes down by 39%. He looked at both observational and RCTs. Our colleagues from Denmark, they looked only at the RCTs, very similar findings. So even if you look only at the higher evidence, the message is consistent. So what do you guys think clinically? Do you see good benefits with these programs? How about you guys? Okay.
It works if they do it.
Okay. So there is an issue with compliance.
I think we can all agree on that.
Okay, definitely. Those of you who work with athletes, what do you do to improve compliance? Does anybody have any great ideas? Yes? And that is where the big problem is, that you have to sell it to the coach and convince him about it.
But also try to, instead of injury prevention, we try also to sell it as performance enhancement, because it also have actually good effects on cutting speed, and running and so on. So I think it's also how we sell it, because injury prevention, not very sexy. Performance enhancement speaks to the coach.
Exactly, and I think when you say not very sexy, I think that's summarized in the number needed to treat. So when we implement those programs, we need to train 108 athletes in a year to participate in this program to prevent one ACL injury. Okay, so this is the numbers needed to treat. That's not a good sell for the coaches. Okay, but as Michael said, probably what they care. I mean, of course, they care about the health of their athletes. They also care about injury performance. So most of the athletes they jump higher, they run faster, in addition to preventing injuries. So there is this big debate about what do we do with this injury prevention program? What is the best way? Do we simply give these generic programs like the FIFA 11 Plus to everybody in the team, regardless of whether they need it or not, which has its simplicity and its advantages? Or do we try to do some sort of screening? Depending on the day that you ask me, I can be on either side of this debate. I guess just to play devil's advocate, because there was a lot of discussion in this seminar, in this conference, I do think that there is an advantage in actually, especially those that are easy to identify, those athletes with a high deficits, to actually do a more tailored program. But again, I may change my mind tomorrow. So the components of these programs, plyometrics is a big part there. Correction of biomechanics, and we saw that in a couple of the systematic reviews that we did. So in one of them, we looked at the entire literature of how do these injury prevention programs change the biomechanics of cutting, part of our NIH grant. Now, an optimistic finding was that the shorter courses, those that, injury prevention programs, those that were 6 weeks, even as short as 6 weeks, with each session lasting as little as 15 minutes, they may have, at least equal, but on occasion even better effect on the biomechanics than the other longer and more time-consuming injury prevention programs. Those programs that place emphasis on biomechanical technique correction and individualized feedback have the better results. So it is up to us, the physiotherapists, those who work with the teams to implement those. It's not as simple as here it is, here's a video, do anything you want, because not everybody needs the same. Another study that just came out a couple of months ago at the American Journal of Sports Medicine, who looked at a very similar question, but for landing tasks. There were many more studies here, so we had 28 studies, very limited data on 2 of the deficits, the leg and the trunk. Overall, the injury reduction programs, which is the next change that we made, because we don't want to give the idea to the athletes and the coaches that we can prevent all injuries. So we renamed those to injury reduction programs, that they have beneficial effects in terms of reducing knee valgus and increasing knee and hip flexion, so they can help with the quadriceps and the ligament dominus theories. FIFA 11 Plus, very simple. There were a lot of resources. This link doesn't work anymore, sadly. It has been pulled down from the FIFA website, probably part of the restructuring and a bit of scandal that was in this association a while ago. We have contacted them. A lot of researchers are waiting for answers. However, there are other websites, and this feels a bit like an underground community where we don't know if we should be spreading this information or is it illegal at this point. But we still do. So I do encourage you, if you work in soccer, to use the FIFA 11 Plus. If you work in other sports, take this program, make it specific to your sport. We have a PhD student who is making it specific to netball, which is a sport similar to basketball. Is very popular in Australia, and yeah, use it. If you don't have the time to do all of those things, because they are designed to address all 4 of the deficits, just pick the ones that your athletes have. And, you know, I think that would still be an effective way to approach those things. We discussed a little bit yesterday this editorial. Again, I highly encourage everybody to read this. Our studies have a lot of statistical and methodological limitations. Injury prevention programs, though, they work, have very low side effects, and they are inexpensive. And the question is still out there: should we be giving the same injury prevention programs to everybody, or assessing for risk and then treating accordingly? Then there are, you know, arguments to be made for both sides. Final and probably most important note, thanks to my collaborators from all over the world. As Michael said, I've worked all over the world. I'm moving all around the map, trying to draw something or say something. I still don't know exactly what. The team in Greece, the team in New York, where we do the studies with dancers, in Brazil, where we do a lot of the more mechanistic studies, and of course my PhD students and my collaborators at the University of Sydney. So thank you for your attention.
Thank you very much. So now it's time for questions. So maybe I can start. Maybe even it's more of a comment, because I think the whole now we know that it works, or at least these prevention programs. But there's certain barriers to it at different structural levels. Some is with the athlete, some is with the coach, and some I think even goes up to policymakers in terms of them encouraging coaches that it's part of an education. That if you're a coach, you're also aware of the programs, because let's face it, it doesn't take longer time. You just exchange the good old stretching with a bit of injury prevention program. So how do you think we can reach all these different levels?
Starting with the politics, I do think that strategy needs to be tailored into the culture of each country. If in the United States you convince the top administration, which currently doesn't seem to be able to be convinced about anything that is scientific, but let's assume that that works, then if these instructions come from the top down, nobody will implement them, just because of the culture there. That if the government tells you do X, you ignore them, and then you protest against that. Scandinavia, probably different culture. People may be more open to this idea, trust the government a bit more. Yeah, I think the political may be the trickiest to navigate because it is so diverse. Coaches, I do think that, and other people who work with teams, athletic trainers, it is a matter of coming to conferences like this. Next time, bring a couple of friends with you, spread the word, and I think that's how we can, reach critical mass, and then nobody will be doing the stretching, the static stretching, which has been demonstrated that it does not really prevent injuries, and replace it with an injury reduction program. I think you made an excellent point about maybe not emphasizing so much the injury reduction component, but emphasizing the performance enhancement component, because that's a win-win situation. So yeah, I think different strategies, but first let's complain and be as loud as we can that these programs work. Let's complain and be as loud as we can about the devastating effects of ACL injuries. And I think there is plenty of evidence to demonstrate that. And yeah, I mean, you know, I'm Greek, so the loudest we are, I think the more effective we'll be. Yes?
But should we convince our politicians that that should be determined by law that you should do these exercises? I mean, if they seem to work in order to prevent injuries which cost enormous amount of money for our society.
In some countries this may work. Yeah, you know, that could be easy because you go straight to the top. And then if you're successful, the evidence is there. So if in certain societies, convincing the politicians means that it's widely implemented, then that's definitely, you know, let's go down this path, but let's not expect this to work all around the world. In some countries, the governments are a lot less powerful. More questions? Yeah. Yes.
Yeah, so first of all, thanks for a great talk. A lot of those injury prevention programs that you showed here and that are available have a lot of different components like agility and plyometrics and dynamic balance and stuff like that. So in your opinion, if you only got like 5 minutes or 3 minutes, what would be the most important component to address with the athletes?
I think that to me sounds like an argument for screening and tailoring the program, because if you have 5 minutes, you know, to make your patient achieve the appropriate warm-up status and improve performance and prevent injury, it has to be specific to the problem that they have. Otherwise, you know, it's a bit more generic. So I think for those time pressures, these teams and clubs, they may want to invest in a very thorough assessment at the beginning of the season, where, you know, like 5 people seem to be collapsing into valgus a lot. Let's give you these 3 valgus prevention exercises. You guys seem to have some trunk problem. So when you come in, right, you know, 5 minutes before we start training, you do these 3 exercises. 3 weeks later, you change it. So it's a bit more resource intensive, but it does save time. And if you don't make your intervention specific to the problem that the patient or the athlete has, then it's not going to be as effective, you know. You can still give them the FIFA 11 Plus. It's good. It's going to improve their performance, target maybe some of the deficits that they have, but it does take 20 minutes. If you only have 5, just do the one that they need the most.
Thank you.
Thank you for the presentation. Little sidetracking from the prevention part, but still sticking with the ACL though. So we've been talking with the return to play and how we still need to work on which criteria we use, how do we do it. But when it comes to ACL injuries, say starting off with the elite athletes, like what are the time frames that the research nowadays talks? Like how fast can you get back on back on the field?
After an ACL reconstruction?
Yes.
Okay. If you asked me this question a year ago, you would get a different answer. In the last year, we had 2 good studies that provide a bit more evidence on that. Don't return them to sports before 9 months. So even though our protocols are actually criterion-based now, some of the return to sports criteria, one of the more important ones is time-based. So for every month that they go back to sports before the 9 month, you have a 15% increase in injury. And also HOP tests, there's 4 of them, less than 10% difference from side to side. Ask them, how does your knee feel? How does your good knee feel in a scale from 0 to 100, 100 being perfect, 0 being, you know, completely horrible, and then look at side-to-side differences. Again, more than 10%, they haven't met this criterion, and strength, extension strength, knee extension strength. Also, there is one questionnaire, it's called the KOS ADL for activities of daily living. more than 10% differences there is associated with a higher risk of injury. So if the athletes, actually we had a pre-conference workshop here where we put in a questionnaire the findings from these two studies together, and it's a 9-item questionnaire. If that you check, yes, 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 yes in all 9 of them, then you would expect, based on the research we have at this point, that the risk of re-injury is less than 5%. As opposed to not meeting at least one of them, so the rest of the group, 34%, 38%. So there is a big difference there, and we do have increasing evidence that waiting for longer than 9 months, symmetry in terms of performance and strength, and the patient's rating of their knee are strong predictors for re-injury.
Thank you.
I have one question too, yes. Just a quick one. What do you think, because you showed that there are different risk groups to get the ACL injury, as I understood it, right? And they don't all have similar symptoms. But then you have some tests, like now I think the group in Oslo, they are doing more research on the drop jump landing. So, but if only one group, like the ligament dominant group, shows symptoms for that, or what is your opinion on that? Like, is it good to use still, or should we look further for some more complex tests? Or?
There's always this debate between the complexity of the test and the number of the test, and then the simplicity. So you make it very complex, and we had discussions around this topic in this conference, and nobody implements it. The drop landing test is easy to standardize. A lot of the literature in respect to dynamic knee valgus is around that. It has a lot of limitations, as you're referring to, and the guys in Norway have addressed those and talked about those. I would say, in addition to that, make a couple of other cutting or landing tasks and see if your athlete is consistently demonstrating that deficit, whether it's excessive knee valgus or something else. Make it sport-specific. Okay, so if it's a soccer player, put a soccer ball up there and then tell them that your job is to head that ball and score the goal. While at the same time you are actually taking a video and then assessing for the deficits. Again, it's really depends on the situation and the sport, I would say. But drop landing is has some advantages to it. I wouldn't throw it away just because of the limitations it has. Any more questions? Sure. Yes. Yes, please.
So maybe this is just maybe a comment for us as being the ones that carry the torch back to our clubs and our local regions, is that we've teamed up with health economists to make healthcare or economic evaluations on what does it actually cost to implement these prevention programs and what do you actually gain from it. And we've done it both on overall injuries, knee injuries, and now also on ACL injuries. And the very, very clear message from the health economists doing these analyses is it's extremely cost effective to actually implement these. And then suddenly you have actually a business case that you can take to policymakers trying to both work at like the athlete level, the coach level, club level, but also policymakers. Maybe even making it a law that everybody needs to do a prevention program, because I think it's very, very sound and it's clearly a cost-effective intervention. So hopefully that's something you can also take and push to the health economists in your local areas.
And considering that it's election day in Germany today, maybe vote wisely about those politicians. Maybe we can put it on the political agenda. Where do you stand on the mandatory implementation of the sports injury prevention programs? Maybe some of you will run for office to push for that.
Let that be the final comment. Thank you very much, everyone.